My name is Nadine. Thanks for inviting me back. So we'll spend the next 20 minutes looking at some of the anaesthetic challenges and how this feeds into the surgical and nephrology opinions. For most of the talk, I'm focusing on the smaller children and the large midline laparotomy, where the transplant's being, the kidney's being transplanted onto the larger vessels. So from the anaesthetic point of view, although I'm a paediatric anaesthetist, I very much see that I have two patients when I'm thinking about transplanting a child, because my duty of care is obviously to the recipient, but also I do focus, especially for the live-related transplant areas, that we have a donor, and although I don't meet them, I want to make sure that the process is as smooth as possible so that we give the best care opportunity to both the donor and the recipient. So we try to do this through a thorough workup for theatre, as we've spoken about earlier with Maria. We have a very formalised MDT process. We try to be very clear, open and honest with our discussion, both with the child and with the family. And one of the most important things, I think, is having a high level of communication within the specialist team. So that is within, between the surgeons, the nephrologists and the anaesthetists. And hopefully, if we get those three things right, we've got the child ready for transplant on the day, and we can proceed to hopefully a safe surgical environment, with the hope that that leads to a quick recovery, getting the child and the family out of hospital, because we know that that's best, and get them home as soon as possible. So there are three things that I focus on. So preparation, both in terms of a long workup, which may take months, and then thinking about the preparation in the 24 hours beforehand. Thinking about how I'm going to manipulate the physiology so that a large kidney can be transplanted into that small recipient. And I think anyone who goes into this would be naive to not undertake some sort of thought process around the psychology for the child and the family. So we've got a brilliant MDT process. As we said, it occurs monthly. One of the anaesthetists will attend. But actually, the MDT relies on the larger surgical specialties, the nephrologists, surgeons, anaesthetists, but also we can't do it without the CNSs, we can't do it without the ward nurses, the play specialists, and we have a very brilliant resource by which we can get cardiologists, respiratory, to look at those patients early on and follow them through that process. Our transplant patients are recurring visitors for surgery and anaesthesia, and that's why it's important to also remember the psychology. So some of these children will need to come for scans or lines before we even get to the main transplant day, and then post-operatively they're going to need their stent removed. They might need further transplants in the future. They may need fistulas or more lines. So it's really important to think about how you're going to manage the family and you're going to manage the patient. Because if you get that wrong first time, that is a very long process whereby that just culminates in chaos. As Maria mentioned earlier, on the actual day of the transplant, it's important to be aware that perhaps the most supportive family member may not be present for that day because they may be the donor. So why is it anaesthetically so complex? So I've picked out three cases that sort of sprung to mind. I've been involved with all three of these. So they're real patients. The first one is an 8-kilo patient. I think he was about 3 years old, who's coming for a preemptive transplant. I think it's a different patient to Imran's, but also had prune belly syndrome and developed regular ERTs. And of course, came from another country, arrived in the country, came to Gosh, and then 24, 48 hours beforehand, he's got an ERT. So everyone's looking to me, what are you going to do? So great, I've got a patient with prune belly who's got respiratory symptoms, who's having a massive midline laparotomy, who's a very small patient, and who's come from abroad. So everybody wants you to carry on. I did postpone it that day because I think the combination of those factors, once you've got immunosuppression on board, things weren't going to be smooth. And actually we did go reschedule, and it was very successful. The second patient is 16-year-old, 52 kilos, so basically an adult patient who presented to us in acute renal and cardiac failure, required ITU admission, and came to theatre initially for a PD catheter. And I took over from the anaesthetist that started this case, and very shortly after I took over, he arrested on the table. We got him back, went back to ITU, did an echo. It did show some impaired LV function, but definitely not, I would say, in context with the clinical situation, which is obviously a common problem with echo. He had some PD for a while. He went home, stabilised, and then came back to us for renal transplant, and that all went smoothly. The third patient is someone who we're working up for transplant currently, 17-year-old who's only 14 kilos, who's got dysplastic kidneys, is already on PD, and has a background of primordial dwarfism, trisomy 15, hypertension. She doesn't really walk. She's got intellectual disability, and usually she's also a grade 4 airway. So she's already come for anaesthesia, for scans, and to get her PD catheter inserted. But you can see from here the age range, the size range, the comorbidities are vast. So we've got respiratory, we've got cardiac, and we've got some unusual syndromes which make the complexities really very big. So our smaller children, as Nicholas said, normally 8 to 20 kilos, will have those large laparotomies. They've got these renal patients, whoever they are, their growth is very much lower than their peer group, and their weight is very small. So when you come to do a transplant in these children, you're trying to manipulate their physiology in order to get that kidney perfused. So if you've got a fit and well dad who's 80 kilos and you want to put that kidney into a 10-kilo child, we're looking at what blood pressure would be optimal. Obviously, everybody wants you to hit the donor blood pressure. If they're fit and well, that might be possible. If they've got hypertensive disease, it might be very difficult. In a child who's only 10 kilos under a general anaesthetic, this is going to possibly be difficult. So you have to have some strategy of how you're going to achieve this, or formulate some negotiation with the surgeons. So renal perfusion, just to go back to basics, in an adult, 20% of your cardiac output is expected to be delivered to the kidneys. So they are expecting 600 mils per minute per kidney. And if you think about a 10-kilo child, their circulating volume is only 750 mils. So when you go to reperfusion, if you've not got your strategy in place, you've not got your volemic status sorted, you either neither going to reperfuse the kidney well, or you're going to have massive cardiovascular collapse on the table. As I've said, our children are regular attenders, so they'll pretty much tell you what they want. We try to be flexible and adaptable. So gas or intravenous induction, but really I want to know what is their preoperative hydration status. It's no longer necessary to starve children or adults for prolonged periods. They can drink up to an hour before surgery. So in terms of starvation, that shouldn't be a problem. But I do want to know what's their dialysis situation, when did they last have it, what's their normal fluid restriction. We're not keen on dialysis on the morning of surgery. Occasionally it is required, but it is unusual, and it will be seen on induction with profound hypotension. You're going to need invasive lines. So as we talked about earlier, we tend to scan the neck if they've had a lot of lines before, so we can assess where it's best to insert those lines, and you're going to definitely need some kind of invasive monitoring. In terms of intraoperative management, so you need very good IV access. This isn't always easy in these children because volume replacement is quite massive, and I would expect in these smaller children to be giving in a range of 150 to 250 mils per kilo of fluid. So when you first start doing these transplants, it seems like an insane amount of fluid to give a child, but that is generally what is required for these smaller recipients. I will definitely need some form of central venous line for being able to give inotropes. If they've got a permacath or a vas cath already in situ, then I may choose to use that rather than inserting another venous line. Monitoring, we do central venous pressure monitors. This is not looking at a number, but just at the trends that develop. And in terms of arterial line, definitely for the small children, this is massive surgery onto the major vessels, so I need an arterial line. In the larger children, I probably tend to avoid inserting unnecessary lines, especially thinking towards the future, if that child may come back for further transplants or need a fistula inserting. Probably an arterial line isn't necessary in those larger recipients. It's a large amount of fluid that you're going to give, so be sure to warm, be sure to monitor temperature, and then you can think about whether it's possible to do more formalised cardiac output monitoring. In terms of fluids, this is ongoing debate, which I'm not sure will ever be sort of sorted out, but paediatric fluid management is sort of based on the 1950s, and it's still managed around that. We haven't moved massively on. So that's from studies by Holliday and Cigar, and that's really where that 421 rule for maintenance fluids came from. And much of paediatric fluid management is based on that, looking at using, 0.45% saline with some sort of dextrose. This isn't what we're aiming to use in the surgical population, and it's not appropriate. It can lead to so I've written hypo, but hyperglycemia and hyponatremia in a post-operative surgical patient, and it's absolutely not useful for large fluid shifts. So when I assess the child, I look at their baseline fluid requirements and their electrolyte balance. I will look for a period of months over their blood results, particularly looking at how they handle potassium and whether that's been a problem. As I said, I want to know when the last dialysis was, what their fluid restriction generally is, and I'll do an early blood gas intraoperatively to try and get a feel for the child in terms of how dehydrated they are or what their electrolyte disturbance might be. So you want to note your starting potassium and you want to note your starting hemoglobin. Again, because of a really thorough and prolonged workup, our children's gases are normally excellent and hemoglobin is optimal. Sometimes with a deceased donor, it might be slightly different. But with large amounts of fluid that you're going to give intraoperatively, the hemoglobin is probably going to drop a bit. So you need to have some sort of strategy about what's the lowest hemoglobin you're going to be comfortable with, because these are the children that we don't want really at all to give any blood transfusion to. So targets here might be quite different to other surgical populations. In terms of dextrose, it is very unusual to require dextrose, and we would completely avoid it unless there is a specific metabolic or endocrine reason whereby we'll run a small maintenance dextrose infusion, but that won't be separate to our fluids used for improving volemic status. We're going to monitor it as we do hourly blood glucose and gases. Patients obviously have a stress response to surgery where you'll see a raise in glucose anyway, despite dextrose. And the thing with dextrose is it will also cause a hyperglycemic osmotic diuresis. It will just cause you to give more fluid, so you're sort of chasing your tail. Third space losses. So the reason why often we don't need to give a blood transfusion is due to third space losses, although apparently this is a controversial topic. So there are studies suggesting its non-existence. Other studies saying that the losses can be quite huge, up to 15 mils per kilo per hour. Over the past decade, there's been a sort of roller coaster in change, particularly in adults, where they're trying to formalise cardiac output monitoring, particularly in renal transplant, looking at using cardiac output monitors for goal-directed fluid therapy. So they're using these monitors to optimise the hemodynamic variables and then adjust the fluids according to that. So we have both of these at Great Ormond Street, the esophageal Doppler, which is the bigger one on the bottom. That works by looking at flow of blood through the aorta. So obviously in these small recipients where you're clamping the aorta, you're going to have a period of time when that's not going to be that useful. We have Lidco, which we have used for a couple of years. We used it for about 18 months in the renal transplants to see if it would change our fluid challenges, but it actually found it just correlated with what we were already doing. These cardiac output monitors are not validated in children, but they may be useful, and particularly in the older adult-sized patients, if you have them, they're a good addition to the other clinical variables that you might be looking at. In terms of what fluids you're going to give, obviously we've got colloids and crystalloids. So there are natural colloids, blood, which, as I've said, we always have 4 units on standby should we have a sort of catastrophe, but it's something that we really want to avoid. And you will see the next day, once the patient hopefully has started passing urine, that huge amount of fluid that we've given intra-op has already either been passed out or has been lost through to third spacing. So where the hemoglobin may have dropped, by the next morning on the ward round, it's elevated back to normal. So if you've given a blood transfusion, you're going to see a very high hemoglobin. Albumin is, I think, still popular in paediatric medicine. It's never really been something that we do in anaesthesia. The adult papers have shown in a variety of contexts of surgical populations and medical situations, albumin has poor outcomes. So it's not something that I would naturally want to use. In terms of synthetic colloids, starches and the dextrans have completely gone out of favour and we don't have them in Great Ormond Street anymore. They're known to cause bleeding. They can cause, some of the larger molecular dextrans can cause renal failure in themselves. We still have some of the gelatins lying around, and depending on the situation, they can be useful as they stay in the intravascular compartment longer. So if you have a very prolonged surgery and you're struggling to maintain volemic status, they can be useful. But really, the studies show there's not a huge difference between colloids and crystalloids, so we veer to crystalloids. So we've got 0.9% saline. Again, in paediatrics, this is something you would normally use as your fluid bolus in a sick child. And it is good. It doesn't contain any potassium, so that may be useful if you're struggling with a potassium load. But it does cause a hyperchloremic acidosis. So it's not something I would use in vast quantities. So we're looking now towards Hartmann's and Plasmolite, both of which have got osmolalities similar to plasma and an electrolyte component similar to plasma. So they're naturally what we've used for decades in anaesthesia, and it's definitely become more popular. One of the nephrologists has recently done a study looking at the use of Plasmolite in renal transplants. So then we move to the what can be an intense moment, reperfusion. So as an anaesthetist, one of the surgeries I really monitor the stages of what's happening up until that point, and I try really hard to have the patient completely ready for reperfusion. I would hope the surgeons give me some kind of warning, and they do normally, that they're going to release the clamps and they're going to do it in a timely, controlled manner, and we're going to talk about what's happening. And for the most part, that's fine. And if the kidney turns pink quickly, there's a sigh of relief and everybody's very happy with themselves. But if that doesn't happen, there's a lot of looking at my monitor, what's my blood pressure, how much fluid have you given, do you need to give some more fluid? So I've been doing this for about 10 years, so I expect these questions every week. So it's my duty to know how dry that patient was at the start, and it's my duty to make sure that they're at the right volemic status at the point of reperfusion. So I can be quite confident using those monitoring values that I've spoken about and knowing what's normal for a renal transplant, where I am in that phase. I've also got my drugs ready, so I've normally got phenylephrine boluses, which sometimes keep the surgeons happy because I can give them some false numbers. I've got some inotropes on the end of the line ready to go. And then we sort of battle it out. And if I'm absolutely confident that I've done my bit, then normally we now have a very good relationship where I can say, I think I'm okay with my side. Do you want to have a look at the kidney? Because there are other reasons, apart from fluids and blood pressure, why that kidney's not reperfusing. So the position of the kidney, is there any thrombosis? Have you just been jabbing at it for a little bit too long? Can you give it a break for 5 minutes? In terms of inotropes, every institution is different. I would say we veer more to using dopamine. That's not due to renal protection, but I think the surgeons are a little bit more comfortable with dopamine, and we think that it maybe causes a little bit less vasoconstriction and therefore perhaps has a lower risk of thrombosis. In truth, I'm not sure there's any sort of realistic truth to that. There's not a right inotrope or a wrong one. In some patients, particularly the cardiac patients where we don't want a raging tachycardia, then I'm going to probably veer to noradrenaline. But these are normally required. It would be normal to have those on at reperfusion, and maybe in the smaller children, that's going to continue into the ICU. In the patients that we can wake up a little bit sooner, we can normally have the inotropes off by the time they get up to the ward. This is a brilliant surgery for me because I can see the physiological changes in front of my eyes. You can see the kidney picking up. You can get a feel for how well you've done your job by the stability of the patient at reperfusion. For our larger patients who are going to go to the ward later, we would do transversus abdominis plain block at the beginning of surgery, and the surgeons kindly will insert a catheter under direct vision at the end of surgery, and we'll start a local anaesthetic infusion. And this has been really quite great for the patients that are waking up straight away and going to the ward. They still have a morphine nurse-controlled pump or patient-controlled pump, but the amount of opiate that's required has dropped dramatically, which means they're more alert, they've got less nausea and vomiting. In terms of the smaller patients, obviously they're going to remain sedated and go to ITU. So thinking about post-operative care, we want to continue all that work that we've been doing intraoperatively into the post-operative period. So sometimes once the kidneys reperfuse, everything's looking good, the patient's diuresing, actually you've still got to maintain your bulimic status, avoid hypotension, and do all those good things for quite a few hours after before you actually get them up to the unit. So you can, if you're not careful, get behind again on fluids. So you need to keep monitoring everything. So we want to close the abdomen without impinging on our ventilation. We're going to remain fully sedated, probably for 12 to 24 hours. We want to ensure we've got good analgesia. We want to avoid hypovolemia, hypotension. Again, where possible, avoid transfusion. You might want to let that hemoglobin drop to more around the 5-6 mark. Keep your maintenance of monitoring, and there's another team that's getting involved here, and that's ITU, who also have a different outlook on things sometimes. So that's why it's really important to maintain that high level of communication. And at that point, we do a very thorough handover between nephrology, surgeons, anaesthetists, and ITU to ensure that all these things we've been aiming for to get that kidney working continues until that patient's awake. And that's all.
Okay, thank you very much, Nadine. Any questions for Nadine? Basically.
So you didn't tell us what blood pressure you consider minimum.
Well, I've got different views. So the reality is, if you put somebody who's fitting well under a GA, you know, their blood pressure drops dramatically, they will still pass urine. If they're on an ITU and they're sedated, even an 80-year-old man will pass urine at a much lower than I think in general the medical population will accept. For the surgeons, I think I would say 100 is a popular number. Ideally, if I can get the blood pressure to a similar level of the donor, which I think if it's a fit and healthy adult, I think 100 to 120 systolic is very reasonable. That's achievable. But in an 8-kilo child under anaesthesia, we're talking about using a lot of inotropes. And then you're into the risk versus benefit. Just me squeezing everything up, is that going to actually cause problems for the kidney? So I think it's just communicating, but aiming for a realistic number above 100, I think is fair.
Anish?
Thank you. So we tend to sort of sometimes ask the surgeons what was the perfusion sort of pressure, and sort of thankfully when they wake up, they've got a higher pressure just because of pain.
Pain, yeah.
The question I had was, is there a weight which you think pediatrics should reconsider? Because we are quite used to, I'm thinking of the big patients, we've got patients now sort of 12, 90, 100 kilos, and we are sometimes at risk of giving, not thinking about it as adults because we're just not used to our expertise with young children, as you said. Is there something along those lines that you think we should reconsider and just...
In terms of blood pressure?
In terms of just how we think about our transplant patients when we are taking them for transplant and they're a very big way.
I think that's when cardiac output monitoring is genuinely useful because they will need much less fluid. So I think if you can use a LIDCO or some of these cardiac output monitors, which is what they're doing in adults for renal anyway, I think you'd be able to guide your fluids much better, not sort of overload just for the sake of giving fluids. So I think that would be useful.
More questions? No, Nadine, thank you.